The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
E ngā matawaka o te motu, tēnā koutou katoa. He mihi aroha ki ngā tangata moemoeā. Thank you very much to the conference conveners for the invitation to speak today. It's nice to be back in Australia again, and nice not to be talking about standards for a change. So that's a bit of a thrill. Apologies to those of you who may have seen me speak earlier, because there is a little bit of repetition here, because I know that not all of you will be aware of how New Zealand is set up. So these first couple of slides are duplicates, I fear. So the Health Quality and Safety Commission, it's taken me a long time to realise that the New Zealand one is quality and safety rather than safety and quality, but I'm getting there. And it was set up in 2010. And its role really is about providing advice and coordinating and supporting. So unlike the Australian Commission, it has no role in accreditation or in setting standards, and it operates entirely through influence and persuasion, though there are some levers in terms of indicators and access to data. New Zealand is quite different from Australia in the fact that there are national data sets that can be linked with the National Health Identifier. So the Commission is in the sort of lucky position of being able to beat people over the head with data. Though there are the usual challenges with coding and so on, so there are some limitations there. So I work for the Patient Deterioration Program at the Commission, which was funded a year or so ago for a 5-year period with scope to improve and standardise the care of deteriorating non-pregnant adult inpatients in New Zealand hospitals, though that scope seems to be expanding rapidly with some recent work looking at paediatrics and maternity. And I fear I am cursed somehow with having to keep playing with observation charts for the entirety of my career. So this is the obligatory picture of the New Zealand health system. So we have 20 district health boards, which are similar to local health networks. Those district health boards are of varying shapes and sizes. So many of them have more than one hospital. There are, I think, 14 ICUs in New Zealand, so not every DHB has an intensive care unit, and certainly not every hospital has an intensive care unit. The DHBs are funded centrally to provide public health services for free, and their resources really vary depending on the population that's served and the services that they offer. The size of the hospitals really ranges pretty widely from about 30 beds to about sort of 700 or 800. So I'm going to talk a little bit about rapid response teams and the kind of history in New Zealand, and it's not too dissimilar from Australia, other than being a little further behind the 8 ball, I guess. Rapid response teams in New Zealand have really been spontaneously developed, and in similar sort of state to Australia. There's been no additional resource really, and it's somewhat unclear what the effectiveness of these teams has been. So I'll talk about each of those things in a bit more detail. So this is a paper that I'm afraid I've got to acknowledge Alex Sirides at the back there, because we are basically the same person these days, because we trot around the country talking about these things. So I've poached a number of his slides, but I think of them as mine now. This is from a paper that we did a few years ago where we looked at the clinical triggers for rapid response team calls in New Zealand. So it was basically a survey study of DHBs where we asked them to send us their stuff. And really what we found is that there's considerable variation in the vital sign triggers for escalation to rapid response teams, and none of it was particularly evidence-based. There's also variation in response, and the sort of current structures. Everybody theoretically has some kind of escalation process in place, but many of those are not mandated, and none of them are particularly well resourced or resourced at all, and there is very little in the way of data that is reported either locally or nationally, and very few studies, as you'll see shortly. So what we've done over the last year or so is developed a national vital sign chart, lucky me, which we have trialled in 6 early implementation sites, including site who are have been implementing an electronic vital signs system so that we can look at how does the early warning score look in that context. And that's been very useful in terms of trying to model workload and things like that. We have asked people to develop their own local escalation pathways as part of that process, and it's clear that there's really significant variation in rapid response team membership and in the clinical skills that are available at the bedside when a rapid response call occurs. So in these 6 sites, call responses range from calling an ambulance in an elective surgical hospital to a duty nurse manager and a house officer showing up in a small regional hospital, to a full intensive care-based MET team, which included, ICU liaison nurses or the equivalent, an ICU registrar, a medical house surgeon, orderlies, the whole shebang. Interestingly, I believe that none of the sites provided any additional clinical or non-technical skills training to responders prior to implementation. And I guess while it reflects the realities of the resources available in the different sites, it really calls into question the efficacy of such teams in actually treating the problem and achieving the goal of providing senior and skilled clinical intervention for acutely unwell patients. I mentioned this in the talk earlier as well, but I think it was a very salutary lesson for us in the difficulties that we're going to encounter as this program unrolls across the country. There was one of our sites where there are no registrar-level clinicians working in the hospital, and implementation really highlighted some very long-standing organisational issues around the safety of the hospital at night. In that case, the senior doctor group ended up involving the union when they were presented with the escalation pathway because they felt that a requirement to respond at night time was remodelling their job description. And, it was an incredibly complicated thing for the project team to navigate. I guess the side effect of that has been that the CEO and the senior executive and clinical leaders in the organisation are now having to pay some attention, and they did in the end navigate their way through it with a compromised position where when a rapid response team call occurs, the responding house surgeon is now obliged to telephone the SMO. So we'll see what that does in terms of patient outcomes. Now, forgive me, I know I have a slide in the wrong order here because, interestingly, while I was writing this talk, there was a complete power cut in the office. So I'm just going to skip that. This is some data, which is very small numbers, make no judgments here. But I think it's quite interesting. This is data about the timeliness of review of all patients. There's a tiered approach to escalation with the observation chart. So this is any kind of review. The blue lines there are the number of reviews that were triggered. It's an audit sample. It's a random audit sample. It's not strong science or anything. But the red or orange, whatever colour it looks on your screen, line is the number of those reviews where the response occurred in the time frame that was specified in the escalation pathway that was developed locally to reflect local resources. And I think it's very clear that timely responses are quite difficult to achieve in the real world of clinical work, and that you can have the best escalation pathway in the world, but if people aren't actually able to meet the requirements of that escalation pathway, it's likely that there is some risk to patients. I think it's very clear that there is some significant work that needs to be done to improve the capacity of early responders to do what's asked of them, and also to ensure that people have the clinical skills required to serve the patients well. So the theory that early recognition in response to deterioration may not be timely or consistent is supported by this study, again a study from Wellington, from Alex's work, that found that diurnal variation in MET calls exists, similarly to the international literature around this, and that certainly supports the idea that the system doesn't reliably detect or respond to deterioration 24/7. Oops, I pushed the wrong button. So there's also significant variation in resourcing, again, similarly to the international data. And I think that variation in resourcing probably explains a lot of the unreliability of the systems that are currently in place in New Zealand for rapid response teams. Data about resourcing of rapid response teams is almost absent and pretty much appears to be entirely absent in New Zealand. There is some DHB level data about allocation of resources within the DHB. That's only available within DHBs. There is no national data at all. I even went to the length of asking a couple of health economists and a data analyst to find out if there was any ability to find out even whether, you know, money gets split between medicine and surgery and intensive care and how that happens. There's just nothing. It is possible, theoretically, to extrapolate wildly from DRG-coded data, but that would give us a totally imperfect guesstimate at the very best. I think it's important to remember that these kind of systems, recognition and response systems, don't manufacture sick people, and I guess it's reasonable to argue that these are patients who should be reviewed anyway. But I think it's very clear that we don't know what the impact of recognition and response systems is on workload in real terms, and we still don't really understand what the opportunity costs have been in clinical services who provide rapid responses. And, you know, I think it's also important, I know it's an intensive care conference, but I think it's important to think about the opportunity cost for ward staff here also, who are required to provide the earlier responses to deterioration. And, you know, medical registrars are often involved in rapid response teams, and certainly in the New Zealand context are often being removed from their responsibilities admitting patients in the emergency department to do that. So this is not just an intensive care problem. In New Zealand, I guess what we do know is that current models for responding to deteriorating patients are resourced quite differently across New Zealand and consequently vary pretty widely. There are a number of patient at-risk teams, so like ICU liaison nurse teams, with hugely varied FTE, and otherwise there's been zero additional resourcing for any of this stuff. So as far as the Commission's role in all this goes, we have absolutely no ability to directly impact the way that resources are allocated within DHBs. We can provide some evidence about why this matters, but we don't have any money, which means there's a serious gap in our plan for improvement of systems in New Zealand, and one for which we're so far unable to find an elegant solution. I wish I had the answer, but I simply don't. There's also clearly some variation in effectiveness, but again, that's really difficult to know. There have been, I think, 4 papers about the effectiveness of rapid response type services in New Zealand. 2 of those papers are from the same tertiary hospital, and then 2 are from other single centres. The one paper that was a multi-centre study basically tells us the same thing as the international literature in terms of some of the activities of rapid response teams, but there's still clearly a lot of work to be done in New Zealand to find out whether we're doing anything useful at all. Let's hope we are. The Commission certainly has a plan for evaluating the program, and we're going to look at things from a kind of atlas of variation perspective to do that. And we also want to make sure that we include some qualitative information about things like safety culture and changes over time in staff perceptions and experiences of caring for deteriorating patients. So we want to try and look at this more broadly than perhaps has been done with other kind of national programs. So that's the plan. Thank you very much.